السلام عليكم. السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
سامعين كويس الحمد لله. السلام عليكم ورحمة الله. Today's session will be about the liver, pancreas, and spleen. By the end of this session, you need to be able to describe the liver, including its location, loops, borders, and relations, liver peritoneal coverage and attachment, including triangular coronary and falciform ligaments, the porta hepatis and the vascular supply in terms of portal vein and hepatic artery, describe the extrahepatic biliary system, describe the location of the pancreas, its sparse surfaces and relations, describe the location of the spleen, sparse surfaces and relations, and common problems. So this is a liver, the largest organ after the skin, and it is considered as the largest gland. It's about 1.5 kilogram in adults. However, in pediatrics, it represents about more than 5% of the weight compared to the adults, which only represents about 2.5 of their total body weight, which is approximately 70 kilograms. Normally, it is located between rib number 7 to rib number 11, and this is usually in the right side, and it crosses the midline toward the left nipple. So this is very important for you because this is where you do percussion to see if there is a normal liver span or if there is a reduction in the liver, which common in cirrhosis. Okay, as you can see, it is located in the right hypochondrium, epigastric region, and it extends close to the left nipple in the left hypochondrium. It is soft, solid, and this is important clinically. Why? Because if there is a cirrhosis, usually it will be hard. If there is a cancer, it may also be hard. And if there is an abscess or cyst, it may be cystic. Okay? It is friable, mean it is labile to injury, and this is very important because the liver has very rich blood supply. So if there is a laceration in the liver, if it is a small laceration, usually it coagulates itself by itself because liver is a site of synthesis of coagulation factors. However, if it is a very large laceration, you may intervene and need to do lobectomy. The liver color is dark reddish, and this is important clinically because if you do a laparoscopy and you find that it is yellow in color, this may indicate either jaundice or there is fatty liver. Okay. If it is becoming a large, dark, rusty, sometimes this may be a manifestation of hepatocellular carcinoma or angiomas. It has a thin fibrous capsule. We call it Glisson capsule. And usually, as you can see in this picture, it moves with deep inspiration. So what are the external features? If you look into the liver has two surfaces. In some books, they mention 5 surfaces. But this surface, because it is of its proximity to the diaphragm, it is called diaphragmatic surface, which form of anterior, superior, and posterior surface. And this, we call it visceral surface. And the visceral surface is mainly related to the viscera. Okay? There are main features, if you look into this picture, that you need to be able to identify and know. In the diaphragmatic surface here, anteriorly, we have the falciform ligament. Below, or the lower limit of the falciform ligament, we have another ligament. We call it ligamentum teres hepatis. Also, posteriorly, we have this area, which is very important clinically. We call it pear area of the liver. And we have the groove for the inferior vena cava. And we have here a fissure for what we call ligamentum venosum. The visceral surface, on the other hand, here the ligamentum teres hepatis passes to form us, to give us this fissure. Also, we have the gallbladder groove and we have porta hepatis groove. Okay. The liver has 2 notches. It has a notch here for the gallbladder and another notch here for the inferior vena cava. So, if you look at it, you will find that posteriorly here it has H-shaped appearance. This H-shape has anterior stem, right, which is the inferior vena cava. Posteriorly, or inferiorly, we have the gallbladder. Here we have ligamentum venosum, which is a remnant of ductus venosus. And here we have the ligamentum teres hepatis, which is a remnant of left hepatic vein. And here the H stem or transverse stem represents the porta hepatis area. The importance of this is that during embryonic life, because you don't need the liver, nutrients come through the hepatic veins. They bypass the liver by passing through the ductus venosus to the inferior vena cava, and from there go to the right atrium. This area, which we call it the porta hepatis, it's very important area because it accommodates structures going and leaving from the liver except for hepatic veins. It has bile ducts, right and left, portal veins, right and left, hepatic arteries, right and left, in addition to sympathetic and parasympathetic tributaries, which are distributed to the liver, and lymphatic exiting the liver to the celiac lymph nodes. So if you want to know what are the loops of the liver, usually we divide the liver into 2 loops anatomically. We have the right loop of the liver and left loop of the liver, which is divided by falciform ligament and ligamentum teres hepatis, and posteriorly by ligamentum venosum. So this is the right loop, and this is the left loop anatomically. The right loop, as you can see in this picture, it is very large comparatively to the left loop. It almost represents about 5/6 of the liver size. It characterized by having 2 extra small loops. We have here a quadrate loop, and this quadrate loop, because it looks like a square, it is bounded to the right by the gallbladder and to the left by ligamentum teres hepatis, and posteriorly by the porta hepatis. Okay, we have here another loop which looks like a comma, and we call this caudate loop. And the caudate loop is located between the inferior vena cava and ligamentum venosum, and it has a process which extends between the porta hepatis and inferior vena cava. Okay, we call it caudate process. We call it caudate process. The other thing, if you go a little bit to the left of the caudate process, you will find this, and this looks like a finger-like projection. Therefore, we call it papillary process. Papillary process. The left loop, on other hand, is characterized by having this tuberosity, which we call it omental tuberosity. And as its name implies, this omental tuberosity is intimately related to the stomach. Therefore, if there is a cancer in this area or in the left loop, usually it may extend to involve the anterior aspect of the stomach. Okay? There is another classification which we call it the functional lobes of the liver. This important from physiological perspective, and also it is important in surgery when you want to do resection of functional loops. We divide this based on what we call Cantel's plane or line. This is an imaginary line extending from the inferior vena cava above to the gallbladder below. It divides the loops into right and left. Still, the right is larger than the left. Each one of these loops has a specific portal artery, portal vein, and it drains into a specific hepatic duct. We have the caudate loop, and the caudate loop, we consider it as a third loop because it has its independent blood supply from the portal triads. So it receives its blood supply, hepatic artery and portal vein from both sides. And usually it drains by its own hepatic veins, which are usually two, just distal to the three hepatic veins. Okay? طبعا اخذته في الامبريولوجي انه usually we have three hepatic veins. If you have one hepatic vein, this is incompatible with life. If you have two, you can survive. But the normal pattern is having three hepatic veins, and these hepatic veins, they drain directly to the inferior vena cava. Okay? When these two loops are further subdivided into 4 subdivisions, then these are further divided into 8 surgically resectable hepatic segments, which will be described to you later, inshallah, in physiology and in clinical practice. What are the ligaments of the liver? There are what we call true ligaments and what we are called false ligaments. False ligaments implies they are nothing more than peritoneal folds. As you can see here, we have the falciform ligament. We have right and left triangular ligaments. We have coronary ligament, anterior and posterior. The other name of it, the posterior one, reflect on the posterior abdominal wall to give us what we call hepatorenal ligament. And we have lesser omentum around the porta hepatis. These are peritoneal folds. But we have 2 ligaments, which are true ligaments, which are ligamentum teres hepatis, which is a remnant of the left umbilical vein, the obliterated one. And we have here ligamentum venosum, which is a fetal remnant of the ductus venosus of fetal circulation. So the liver has peritoneal relations. Why you as a doctor need to know this? Because liver is a site of cancer. So a tumor in the liver may infiltrate the surrounding. Also, any tumor in any one of these structures, if it become invasive, it may infiltrate the liver, result in drastic effect. Generally, you need to be able to know that the liver is intraperitoneal structure. So it is surrounded by peritoneum. However, there are certain areas which are devoided from peritoneum. Like here, we have the pair area of the liver, which is bounded by the anterior coronary, right triangular, and posterior coronary. Also, we have the fossa for the inferior vena cava, and sometimes the inferior vena cava may be completely embedded within the liver, and this is clinically important because if there is a tumor, if it is completely embedded and there is a tumor in the posterior aspect, this may result in compression of the inferior vena cava with dilatation of the lower limb abdominal veins and hemorrhoids. Okay. There is also this area, which is the gallbladder fossa, though it is devoided most of the time, but sometimes it may have a mesentery, and in that case, it will be intraperitoneal. We have this groove for ligamentum venosum. It's also devoided from peritoneum. What are the relations? As you can see here, this is the diaphragm. I want you to look into this picture very carefully, because this is very important in clinical practice. The right boundary or the right surface of the liver has three different relations. The upper one is related to the diaphragm, and as you can see here, the lower part of the lung. Here we have also the right lung, diaphragm, ribs, and intercostal, while below this level, you may only find the diaphragm. You may not find the lung. So what is the importance of this? The importance of this is when you want to take a biopsy from the liver, usually we go between 9 and 10 to avoid injury to the pleura and to take a biopsy from the liver. If you went higher up than this, you may injure the liver. The other clinical importance of this is that the 7 subcostal space, if you go to do thoracostomy or to insert a endothoracic tube, you need to be careful not to pass through the diaphragm and injure the liver. Okay, and superiorly, as you can see here, we have the diaphragm. Here we have the cardiac impression, which is due to the right and left ventricles. And posteriorly to that, here we have the right atrium and opening of the inferior vena cava. The left side superiorly is related to the left dome and of the diaphragm. Okay. Anteriorly, the liver is mostly covered by the ribs and costal margin and the xiphoid process. However, there is also anterior abdominal wall muscles like rectus abdominis, external, internal, and transversus abdominis muscles, mainly in the right and left side. Okay. Posteriorly, we have peritoneal coverage, as we said, except for the bare area of the liver. Here we may have the kidney and the suprarenal gland, and here we have what we call hepatorenal pouch. This area is related to the colon. That's why we call it colonic impression. Okay. Here we have the stomach, and here we have the esophageal impression. So if there is a cancer in the lower 1/3 of the esophagus, it may infiltrate the liver. If there is a tumor in the left loop, it may infiltrate the esophagus, or it may infiltrate the stomach itself. Okay. If there is a tumor in the anterior aspect of the stomach, it may infiltrate also the stomach. If there is a tumor in the suprarenal gland and right kidney, there is a separation because there is a hepatorenal pouch, so it's unlikely to be infiltrated because there is no intimate relations. The blood supply of the liver comes from two sources, hepatic artery and portal vein. It's very fascinating because here the veins are very important because they provide a large amount of blood supply, almost about 3/4, and it provides about 40% of oxygenation to the liver. Bear in mind that portal vein is important for the parenchymal part of the liver. In contrast, the hepatic artery, which mainly provide oxygenation, about 60% of oxygenation, is mainly important for non-parenchymal part. That is to say, connective tissue and ducts, bile ducts. The portal vein carries all nutrients apart from lipid, because the lipid goes to cisterna chyli, and from cisterna chyli they go for through thoracic duct to be coming back through the blood. Okay, so portal vein carries all nutrients up except for lipids. As I said, we have 3 or more hepatic veins. They are one of the stabilizing factors because they drain directly into the inferior vena cava. Okay, liver, as you will take in histology, is characterized by having sinusoids, and these sinusoids, they contain what we call Kupffer cells, and the Kupffer cells are very important in protection of the liver against invading bacteria. Okay, we have what we call also portal triad, and the portal triad, as you can see, are formed by common hepatic ducts, portal vein, and hepatic arteries. They branch to give different segments, and from there, as you can see, we have the veins which are drained to the hepatic vein. So the area of high oxygenation is the area close to the portal triad. Area of low oxygenation is the area close to hepatic vein. And this is very important to remember because of the toxic effect. Usually the toxic effect affects area close to the portal triad, while areas due to reduction of blood supply usually affect area close to the central veins. For the lymph drainage, the liver provides about quarter to 1/5 of the lymph of the body. It passes through the celiac mainly. However, it may spread. Also, it may go from the bare area of the liver to the phrenic and posterior mediastinal lymph nodes. In the left loop, it may spread to the left gastric, parasternal, and anterior abdominal walls. So, why you as a doctor need to know this? Because there is a specific type of cancer which we call cholangiocarcinoma, which arises from the ducts. It may spread through lymph early, and in that case, the initial identification criteria may be finding an accidental enlargement of lymph nodes, either in the mediastinal region or in the celiac lymph nodes or phrenic. If that's the case, if you find it accidentally, you need to think of cholangiocarcinoma or hepatocellular carcinoma. The liver has branches coming from it from the celiac, and actually it is the largest branch. The sympathetic arises from the celiac, while anterior and posterior trunks of the vagus contribute to the parasympathetic component of the celiac plexus. So what are the structures that support the location of the liver and keep it in place, though its weight is 1.5 kilogram? We have ligaments like coronary and triangular ligaments. Inferior vena cava, the pressure from the abdominal viscera, atmospheric pressure, falls from ligament. In some books it is mentioned. However, it is not that important for support. We spoke about subphrenic and subhepatic in the clinical lecture. Liver rupture is, as I said, it may heal itself if it is a small, but if it is large, you may need to do resection. Cirrhosis is abnormal condition following viral infections or alcoholism or or fatty liver, and in it you will find abnormal or distorted pattern of septa, and it has 2 types. It has macro and macro types. هيجدكم إن شاء الله في الباثولوجي. Hepatomegaly can happen either in response to infection. It can also be a response for anemia as a source of extramedullary hematopoiesis. In cardiovascular cases, it may due to right side heart failure. If you find irregular surfaces of liver, you need to think of cirrhosis or malignancy or tumor. As I spoke, liver is a common site of biopsy. Usually we do it now and ultrasound guided. It can be either from the right side or transabdominal. Here you need to be very careful that there is a lot of variation in blood vessels, and the liver is a site of hemangiomas, arteriovenous mal formation. and angioblastomas. Okay, so let's look into metastasis and how it appears. Since liver receives a large amount of blood supply, it can be a site of metastasis coming to it from different areas in the GIT. So cancer of pancreas, cancer of stomach, colorectal cancer can spread and give us multiple foci in the liver. Okay, this is the appearance of CT, and as you can see, we have here the spleen. This is stomach. Here we have the aorta, and this is the inferior vena cava. Okay, this is the area of porta hepatis. Also, there is a condition which we call portal hypertension, and this is usually follows fibrosis around the portal vein. It can be the common cause is schistosomiasis or bilharziasis. However, it may follow liver cirrhosis, advanced stages, or even cancer involving porta hepatis region. This may result in opening of anastomotic channels collecting between portal vein and systemic circulation. Namely, we have here the lower one-third of the esophagus. As you can see, this is esophageal varices. It may be traumatized for any reason, resulting in massive amount of bleeding and sometimes shock and death. Spleen also, because if backflow, it may cause grossly enlarged spleen. Spleen to be palpable, it needs to be double its size or more. So if look into the spleen here, this is a normal size. Here now it become grossly distended, and this is a sign of portal hypertension. As we spoke about in the umbilical region, you may have what we call caput nodosum, and here we have hemorrhoids in the lower junction between the inferior rectal vein and middle rectal vein. The other one, it's the pear area of the liver also may have a grossly distended veins. So the bile is secreted from the liver and goes through what we call extrahepatic biliary system. We have two bile ducts, two hepatic ducts, unite together to form common hepatic duct. This hepatic duct unite with what we call cystic duct to give us what we call common bile duct. Here we have the gallbladder, and the gallbladder is formed of a fundus, body, and a neck, which drain into a cystic duct. How the bile goes for the gallbladder? Bile comes from the right and left hepatic ducts, drains down to the common hepatic ducts, then goes down. Here in this area, we have a sphincter of Oddi, which under the mucosal coverage of ampulla of water. So if you don't eat, this one will be closed. So the bile pressure will increase. Open a valve here, we call it a spiral valve, and the bile will go to the gallbladder to be stored and concentrated. If you eat, cholecystokinin, pancreaticozymin, will be secreted, and this will relax the sphincter of Oddi and stimulate the contraction of the gallbladder, so the bile will go down to the second part of the duodenum. The gallbladder is a pear shape. Its size about 7 to 8, and its capacity is 30 to 50 ml. What is the clinical importance of this? In certain cases, the gallbladder may have tumor or may have accumulation of fluid. We call it mucocele of the gallbladder, or a pus collection, which we call it emphysema of the gallbladder. So if you found that the content exceeds 50 ml, so there is a problem in the gallbladder. Also, in cases of chronic inflammation because of healing by fibrosis of the smooth muscles of the gallbladder, the capacity of it will be reduced, and this may be a sign of chronic cholecystitis. The length and breadth are very important in differentiation between empyema and mucocele. So that's why I wrote them to you. The location of the liver is under the surface of the visceral surface or the inferior surface of the liver. It extends from the inferior border of the liver backward up to the porta hepatis, and this is very important because the fundus is intimately related to the anterior abdominal wall in a junction of transpyloric plane with the liver, or what we call ninth right costal cartilage. And this is important because in abdominal examination, if you find a mass or a lump in this region, you need to think that there is a problem in the gall bladder. Posteriorly, it has a very important relations, and these relations are the duodenum. In some books they mention first, and other books they mention second, but you can say first and second as a normal variation. Also, we have the transverse colon, and sometimes you may find the pylorus of the sphincter. The clinical significance of this relation is that sometimes the gallbladder has a stone, and the stone start to rub the posterior surface, result in fistula, and the fistula may result that the stone fall either in the duodenum or in the colon, result in what we call choledochoduodenal fistula or choledococolic fistula. And if the stone goes for the duodenum, sometimes if it is large, it will close the ileocecal valve, result in what we call paralytic alias, an intestinal obstruction. It's rare, but it may happen. The gallbladder is covered by peritoneum in its visceral surface, and however, the liver surface is devoid of peritoneum in most of the cases. However, it may have also mesentery. The importance of this is that the peritoneal coverage of this area receives from phrenic nerve. That's why the pain arises from the inflammation of the gallbladder is felt in the right shoulder, because both of them share the C4 spinal segment. In this area, we have what we call Hartmann pouch, and the Hartmann pouch is present in the area of the neck, usually in the posterior medial surface, and this is usually pathological, and if you find it, it may indicate existence of calcular cholecystitis. Okay? What is the source of blood supply? Hepatic artery, gallbladder receives cystic artery, which has variable origin, usually comes from the right hepatic artery, but it may arise from hepatic artery proper itself, or even the left. The interesting thing is the cystic vein, which usually drains into the portal vein. However, here I want you to remember this very carefully. It drains sometimes into the liver itself. So عندنا في الجراحة, if you cut the cystic duct, we call this point of no return. You need to remove the gall bladder. Okay. Sometimes we shave the gall bladder if you couldn't remove it totally, because the part of the gall bladder intimately related to the liver can receive blood supply directly from the liver. Okay. We have the lymph nodes, and the lymph nodes usually follow the cystic artery, and they go for a very important lymph node located in this area. This area we call it Callot triangle, area between the cystic duct, right hepatic duct, and the inferior surface. Here you find the cystic duct. In this area we find a lymph node, we call it lymph node of Lund. Lymph node of Lund. Contraction of the gallbladder is mainly through cholecystokinin. Okay. The cystic duct is 3 to 4 centimeters. Why I need to know this as a doctor? Because sometimes it's grossly long, and this may make it mixed with common bile duct, and you may cut the common bile duct thinking that it's a cystic duct, resulting later on in obstructive jaundice. So you need to be aware about these variations. The cystic duct has spiral folds, and these spiral folds are very important to keeping it open, so it allows the backflow of the gallbladder. Also, if the gallbladder is contracting, it prevents dumping large amount of gall bladder contact into the common bile duct. Okay. Here I want to think very well about the anatomical variation, which we will mention in the next slide after this one. We have the common bile duct. Common bile duct is very important in medicine. Usually it is 7.5 5 centimeters, and the diameter is 6 millimeters. Why this I put it to you? Because if you find that the common bile duct is more than 8 millimeters, this may indicate distal obstruction. Okay, it has three parts: part above the duodenum, we call it supraduodenal; part behind the duodenum, we call it retroduodenal; part below the duodenum, we call it infraduodenal part. This part receives its blood supply from the cystic. This part receives its blood supply from the right hepatic artery, and this part from the gastroduodenal and superior pancreaticoduodenal. Here, I want you to remember this, that these arteries, they form longitudinal channels in the common bile duct. So if you want to open the common bile duct, avoid to cut transversely, because if you cut them transversely, you may result in reduction in the amount of blood supply to the area later on. We have the ampulla of Vater, all you know it, in the duodenum. The ampulla of Vater, actually, it's an elevation in the second part of the duodenum between 7 to 10 centimeters from the pylorus, usually 10. It may be major or singular, or it may have a younger sister. We call it minor duodenal papilla. But the ampulla of Vater here, it's surrounded by what we call a sphincter of Oddi, and it has various types of opening. As you can see, usually the common bile duct joins the pancreatic duct, they open together, and which is, we call it Versung duct. The lower part of the pancreas and the lower part of the head, usually they drain into the minor duodenal papilla, which are about 2 centimeters above this area in the second part of the duodenum. These are anatomical variations. I put this slide to you because it's very important clinically in anyone for anticipating the variations. Otherwise, you may cut the common bile duct or common hepatic duct, thinking that you are severing the cystic duct, result later on in obstructive jaundice. If you didn't discover it immediately, it may be a very nasty operation later on to reconstruct the common bile duct. So in this case, for example, you see there is a very long common hepatic duct. In this case, the cystic duct runs parallel to the common bile duct. So sometimes people may think that this is a unit and they ligate it in laparoscopy, result in obstructive jaundice. Also here, you may find lack of cystic duct, and the neck opens directly into the common hepatic duct. This is a very interesting variation because cystic duct is very long and may drain into the retroduodenal part of the common bile duct. It may cross anterior then posterior, and in that case, if you didn't take care, usually people will cut this thinking that this is a bile duct. Here it crosses posterior rather than anterior. In this case, instead of draining into the common hepatic duct, it drains into the right hepatic duct. This is two conditions. We have what we call a Phrygian cap, and this is usually a folded fundus. And here we have the Hartmann pouch. This is usually pathological and indicates existence of stone. Okay. In this condition, this is very serious condition, because in this condition, as you can see, the cystic duct runs very long parallel and drains into the inferior part of the of common bile duct. In this case, you have all of this, we consider it as common hepatic duct, and only this part we call it as bile duct. This results in a very short bile duct. The existence of the bile duct behind the head of the pancreas has variations. Sometimes it's just a slight groove. Sometimes it's a deep groove, and sometimes it's completely embedded. And the clinical importance of this is that if there is a tumor in the head of the pancreas, patient may come with obstructive jaundice. So an elderly patient came with obstructive jaundice, always think of CA head of the pancreas. If you want to do surgery, for example, and we spoke about this before, if you cut the cystic duct and it gets slipped, Usually we enter our fingers here in foramen of Winslow, and we start to obstruct the hepatic artery proper. And by that, we can see the sphincter and we ligate it. I spoke to you about the callot triangle, and this is the area where we usually ligate the cystic duct. We go inside, put a clip here and another clip, and transect between them. Also, lymph, we spoke about the lymphofluent, and this is usually we remove it during cholecystectomy, and if it is grossly enlarged, it may sometimes also enlarge due to cholangiocarcinoma or CA of gallbladder. Okay, this is gallbladder is, as you know, is a site of stones. حيجيكم عندنا different types, cholesterol stones, mixed stones, or pigment stones. Usually, large cholesterol stones are very large, while pigment stones are very small. These stones may go through the cystic duct, then go down to cause obstruction in the area of sphincter of Oddi. In these conditions, we do what we call ERCP, or endoscopic retrograde cholangiopancreatography. We go through the by endoscope to the second part of the duodenum. We inject a dye, and if we find there is an obstruction, we do what we call lateral sphincterotomy or sphincterotomy by cutting the sphincter of Oddi, inserting a Dorme basket and pull the stone. Also, we use this technique if there is a cancer in the head of the pancreas by inserting a stent, and the stent will allow the bile to drain into the second part of the duodenum, overcoming the obstruction. We have the pancreas. Pancreas is a retroperitoneal with the exception of its tail. Pan mean all, Krias mean flesh. It is a large, elongated, soft lobulated structure extending between the T12 L1 in the right side. So in the right side, L3 to the left, which about T12 to L1. It is located in the epigastric region mainly. However, it may extend to the left hypochondrium. Its length is about 15 centimeters. It has a head, and the head has uncinate process. It has a neck, body, and a tail, which is intimately related to the spleen. In the area of the body, we have tuber omental or mental tuberosity, which is also related to the stomach. As you can see here, the spleen, the pancreas mostly is a part of the stomach bed. What are the parts? We have the head here, and it is a discoid head. It is located within the C shape of the duodenum. It has the uncinate process, and this is very important clinically to remember, because the uncinate process anterior to it comes the superior mesenteric vein and superior mesenteric artery. So if there is a tumor or a narrowing in this space, this may result in obstruction of superior mesenteric artery, and by that affecting the area supplied by the superior mesenteric artery. The neck is a constricted part, and it is about 1.5 centimeter. The most important thing about it is that it is intimately related to the commencement of the portal vein by the junction of superior mesenteric vein and the splenic vein to the left. The body is moving upward and backward, crossing here the aorta and crossing here the vertebral column. This area is very important clinically because if there is a crushing injury to this area, may result in hemorrhagic pancreatitis or pancreatic cyst. We have here the tail, and the tail is located in the lienorenal ligament spread to the hilum of the spleen. And this is very important clinically because sometimes in emergency, when we remove the spleen, we may need to resect the tail of the pancreas, and the tail of the pancreas accommodate the largest amount of isolates of Langerhans. So diabetes mellitus may follow. This is the relations. The head is intimately, the most important relation for the head is the common bile duct, right hepatic artery and vein, and in addition to that, the inferior vena cava. The neck, as I said, superior mesenteric vein, port commencement of the portal vein and inferior vena cava. The body, aorta, we have also the 12 vertebra, origin of superior mesenteric artery, and we have muscles, left psoas muscle, left suprarenal, and left kidney, in addition to left renal vessels. And as you can see, all of these are considered as part of the left hepatic, we call it left hepatic bed, stomach bed. Okay. We have here the tail, and the tail we have the left kidney and the hilum of the spleen. So, relations anteriorly is very interesting because the pancreas has attachment anteriorly of transverse mesocolon. So the upper part of it is considered as a supracolic compartment. The lower part of it is a lower infracolic compartment. And as you can see, it's, as I have said, it's part of the stomach bed. Okay. The relation to the uncinate is very important in surgery, and usually people ask about it. Also here we have the head is related to the pyloric part of the stomach. We have pancreatic ducts. We have two pancreatic ducts, a main one which we call it duct of Versang, and the accessory one we call it duct of Saritori. And here the pattern of bile pancreatic ducts draining to the main pancreatic duct, we call it herringbone or herringbone pattern. Usually it carries from the tail, body, and the upper part of the pancreas, and it drains into the major duodenal papilla. The minor duct or the accessory pancreatic duct drains from the uncinate process, a lower part, and it drains into the sanitary, and from there goes for the minor duodenal papilla. Why I need to know this? Because if you go later on, there is what we call Weber resection, or for CA head of the pancreas, where we remove usually the duodenum in addition to the head of the pancreas and do anastomosis between the pancreatic duct and the jejunum. You need to be aware about different pattern of ducts. Here we have double accessory duct, for example. Here we have anastomosis between major minor duodenal pancreatic ducts. Here we have double main pancreatic ducts, and here we have no connection between the major and minor. Here we have a loop or crossing ducts. Here we have a tortuous pancreatic duct. Here we have absence of accessory pancreatic duct. So all of these you may be exposed to in clinical practice. The pancreas receives its blood supply from different sources. The main source of blood supply comes from the splenic artery. We have what we call arteria pancreatica magna, and this usually arises close to the distal end. So this is the arteria pancreatica magna, or greater pancreatic artery. It divides into right and left. It has also a dorsal pancreatic artery, and we call it arteria pancreatica caudalis, close to the tail. And here we have the dorsal pancreatic artery comes from the close proximity of the splenic. These three arteries, they anastomose together, but the most important one is arteria pancreatica magna for the body and tail. The head, because developmentally it arises from foregut and midgut, it receives its blood supply from superior pancreaticoduodenal, from the gastroduodenal, which represents the foregut, and from inferior pancreaticoduodenal, which arises from the superior mesenteric artery, which developed from the midgut. The veins usually go for corresponding part and ultimately drain into the splenic and portal vein, and from there goes for the inferior vena cava. Okay. We have the lymph drainage. The lymph drainage usually drain into celiac, superior mesenteric, and pre-aortic lymph nodes. Here, very important to remember that cancer or tumor arising from the tail or body, they may spread into the pancreatico-splenic lymph nodes, while neck and head usually they drain into the pancreaticoduodenal or superior mesenteric or hepatic lymph nodes. Okay. The pancreas receives celiac and superior mesenteric plexuses, and here you mainly affect the blood vessels, because as you know, the endocrine component is affected by the glucose level, and the endocrine, and the exocrine by the contents of the duodenum. Okay. We have the spleen. It's a wedge shape intraperitoneal mobile structure. it is located between the diaphragm and stomach. It is mainly in the left hypochondrium. However, it may extend partially into the epigastric region. It is purple in structure. It has a very high liability to injury. That's why it's a top emergency in surgery and ER. You need to be aware of it. It is soft vascular mass, and this vascularity is important in hematology because it's site of extramedullary hematopoiesis, site of destruction of RBCs, and also it is a very important immune organ in response to infections and lymphoid tumors. Okay, it is the largest lymphoid organ in your body. I want you to remember these numbers: 1, 3, 5, 7, 9, and 11. It is located between the 9th and 11th rib. Its dimensions is 135, and its weight about 7 ounces, about 180 grams. Externally, it has upper end or posterior and anterior. As you see, the anterior is wider than the posterior. It has anterior border, medial border, and posterior border. It has two surfaces, diaphragmatic surface and a visceral surface. It is directed downward and forward and laterally in about 45 degrees. It runs parallel to the 10th strip. Okay. It has three surfaces, two surfaces, the diaphragmatic surface and a visceral surface. The visceral surface is divided into gastric surface anteriorly, colic surface anteriorly, inferiorly, and we have here the renal surface. Okay. This area, we call it the hilum, and in the area of the hilum, we have the tail of the pancreas in addition to splenic artery and splenic veins. As I said, this is expanded, this is rounded and pointed. The most important thing clinically to remember is that the anterior border has this notch. This notch is very important in abdominal examination. When you see it, it may indicate that this large organ is a spleen. هنجي نتكلم later on in how to differentiate between the spleen and the kidney in abdominal examination. One of the differential factor is the existence of the notch. The diaphragmatic surface is accommodated within the smooth lining of the diaphragm. Okay, as we said, the irregular surface is visceral, which has the three parts. Okay, we spoke about this. What are the relations of the diaphragm? We spoke about it, and here I want you to remember that if you want to resect the diaphragm, the spleen in splenectomy, you need to cut these three ligaments. We have here the phrenico-colic ligament. It supports the spleen below. The spleen is connected to the stomach by the gastrocolic, and this contains the short gastric vessels. And the spleen is connected to the kidney by splenorenal, and it contains the splenic artery, splenic vein, and the tail of the pancreas. Okay, this is very important to remember. Always, ya awladi, always remember this fact. If a patient came to you with a fracture in the 9th left lip, 10 left rib, or the 11th left rib, you need to think that his spleen may be injured. Always think of that. 9th, 10th, 11th rib, all of them, if they got fractured for any reason, you need to think that the spleen may be injured. Okay? The blood supply of the spleen arises from the splenic artery, which is the largest branch, and as we said, the spleen runs superior, inferior in what we call a trough. جزء منه بيكون behind the pancreas وجزء منه بيكون above the pancreas in the area behind the stomach bed. And the spleen ends up by dividing into small branches. We call them segmental branches. Usually they are 5 or more. Here I want you to remember this, and this is very important clinically, that these branches are true end arteries. يعني شنو؟ لما نقوم يتقسم ودي اي segment معينه ما بكون في anastomosis between two adjacent segments. The spleen has 2 to 3 vascular segments. The importance of this comes in sickle cell disease because these arteries, the terminal part of them, we call it peninsular arteries. When they got occluded by the sludge of sickle cell, the distal segment will be autosplenectomized, and by that the condition we call it autosplenectomy. يعني العيان بتاع السيكل سيل ديزيز بعد شويه ما بكون عنده سبلين اساسا لانه حصل له ثرومبوزيس and infarction. The venous drainage will go through splenic vein, and from the splenic vein, as it goes proximally, it receives the inferior mesenteric vein. Then it drains by joining the superior mesenteric vein to form the portal vein. دائما يذكر انه البورتال vein is splenic and superior. لانه في الام سي كيوز مرات بيجيبوا لك انه inferior. No, inferior drains directly into the splenic vein. The lymph drainage goes for the pancreaticosplenic lymph nodes, and the nerve and the nerve supply goes for the celiac, receives from the celiac plexus mostly, and in animals, not like human, because the wall of the spleen has smooth muscles. It acts like a reservoir. So if especially camels, for example, during dehydration, it may contract, pushing more blood volume to the organs, and it accommodates about 12 to 18% of the blood volume in that case. This is how we separate between the kidney and spleen. Usually the kidney is bimanually palpable, while the spleen is only palpable anterior. Okay, spleen has a notch. So these are the two main features separate between the enlarged kidney and enlarged spleen. Any questions? Guys? Any questions? No questions? Yes. Spleen is palpable. No. The spleen, it should not be palpated unless it is twice the normal size. If you felt the spleen, this means it enlarged twice its normal size. Okay? لكن عندكم في conditions كثيرة ممكن تعمل لك enlargement spleen, like leishmaniasis, lymphomas. Kidney is not palpable normally, because it is behind the colon and behind the spleen. So usually you don't feel it unless it's grossly enlarged. هنجي نتكلم لكم عنها ان شاء الله في الurinary lecture في genitourinary. Okay? Any questions? Okay. Thank you. يلا اولادي استودعكم الله في امان الله.